patients are of this caliber. Thank you, Mr. Majid. Our second guest is Ms. Abir Massaad, a PhD and a clinical team supervisor and senior pediatric physical therapist from High Hopes Pediatric Therapy Center in Dubai, who will be in line with what Mr. Majid presented, speaking about rehabilitation in CDKL5 deficiency disorder. Please go ahead.
Thank you for the introduction. So in this topic, I will present you the rehabilitation program in children with CDKL5 deficiency. I will share with you High Hopes Pediatric Center experience. CDD is a rare developmental epileptic encephalopathy caused by changes in CDKL5 genes. The early onset of seizures is the main clinical observation, coupled with cognitive, motor, and visual impairments. A recent study has reported that over 200 different CDKL5 variants are detected in 285 affected individuals, which making it challenging to assess relationship between genotype and phenotype. A recent study, also not really recent, in 2016, a descriptive analysis was published regarding the description of gross motor skills in CDKL5 kids. Authors reported that 62% of this population were able to assume the floor sitting independently. However, 27% were able to stand for 3 seconds independently, and 21% of this population were able to walk independently. So authors concluded that there is a large variability in gross motor skills within CDD. Therefore, the natural history regarding developmental milestones in this population and in CDD is still unclear. Thus, disease-specific evaluation and rehabilitation treatment plans are still lacking. So the natural question that we might ask, which model will be the most appropriate to implement a rehabilitation treatment plan in children with CDD? Based on daily clinical practice, the process of rehabilitation plan is based on 3 different components. First, the child-specific evaluation, where weak and strong areas should be detected and identified in order to define specific goals, individual specific goals. These goals can be achieved in case of the application or the use of appropriate intervention plan. As we all know that CDD is not a curable disease, so a re-evaluation is a must in order to update our goals and to update the child's profile or status. So all these processes aim to enhance functioning in a holistic approach and a family-centered approach as well. So we all know, and Mr. Majid mentioned already, that so far we don't have validated tools in CDD, so this makes our work more challenging, so we cannot monitor our work or we cannot evaluate the rehab work. So what to do in this case? The International Classification of Functioning is a helpful tool. This will help to identify the problems, not only the problems related to the health condition or to the body structure. However, it will help to identify facilitators or barriers related to personal factors, for example, which might be very helpful to define the level of activity and participation in CDD kids. So, for example, a child with CDKL5 deficiency will present with an epilepsy and a low muscle tone. He might not be able to sit independently. However, providing him with an adapted seating system will help him to better participate in all family activities and in the school setting. So this is like a very simple example, but we should proceed with the same, using the same model and the same approach in order to enhance participation at different levels. Based on several authors and different publications, it has been reported that in pediatric rehabilitation services, using the ICF in combination with the goal attainment scaling tool is important, and it will help us to coordinate and standardize the assessment and the evaluation of the outcome of treatment outcomes. So GAS is a method of scoring the extent to which a child's scores are achieved in the course of the PT intervention. Each goal is rated on a 5-point scale ranged between -2 and 2, knowing that the score 0 is attributed to the expected outcome. So what did we use? How did were we able to implement this ICF model and GAS at our sample in these cases? So in this study, I will be sharing with you our experience, our descriptive retrospective analysis based on 5 case series where 5 girls were enrolled in this study. All participants benefited from PT intervention between 2020 and 2022, in addition to other interventions such as speech and language therapy, occupational therapy, vision support, hydrotherapy. All these interventions were provided in a multidisciplinary approach, family-centered approach, and this according to the ICF model. So our clinical evaluation was based mainly on a clinical observation inspired from GMFN and Peabody version 2. However, these tools are not validated, but they are helpful to estimate the level of functional skills in these kids. We introduced as well the SATCO assessment for the trunk control, as well as the physical examination in order to detect skeletal deformities. The age of our population ranged between 3 and 80 and 9 years. All our kids benefited from PT intervention. 2 of them were having regular PT sessions on a daily basis, on an average of 5 to 6 sessions per week. However, 2 of them were coming for 1 or 2 sessions per week, and 1 child was coming for an intensive program for 2 to 3 times per year for a period of that ranged between 3 to 4 weeks. So all the enrolled kids were under medication for epilepsy. 3 of our kids presented with low muscle tone. However, 2 showed a mild dystonia. No major musculoskeletal problems were detected except for 1 child with a mild scoliosis. So at our team, the ICF model helped us to detect primary and secondary problems, to identify barriers and facilitators in terms of personal factors and environmental factors, which helped us to define our specific goals for each child while taking into consideration parent concerns through a team discussion. So on average, 2 to 4 goals were defined and evaluated every 3 to 4 months. In addition to the conventional method of scoring these goals, for this study, the T-score was calculated for GAS. This per year. So this score will take into consideration all the defined goals per year, and then you are able to calculate 1 single score reflecting the overall degree of the goal achievement per year for each child. So this score was also used for our analysis. So comparing this T-score between the baseline and the assessment during the follow-up helped us to better understand the impact of our rehabilitation program on the child, on achieving goals. So in total, the number of goals defined for our population ranged between 10 and 20, knowing that the 4th child were only coming for an intensive program. However, the 5th one, or the girl, the 5th girl only started her PT sessions at our center in 2021. In terms of PT intervention, 2 different approaches can be followed. So the first one is the bottom-up. This approach tends to detect specific problems, most of the time related to the body structure in order to enhance functioning. So for example, when we aim to strengthen the core muscle we are also aiming to improve her sitting skills. Different strategies can be applied in a different way while we aim to implement more functional activities in order to enhance body structure. For example, working on a functional sitting position will definitely improve the low muscle tone at the trunk. So in both conditions, we need to, the child should be engaged and should be motivated through this whole process. So at our center, different strategies are adopted, and you are all trained in using these techniques: the NDT approach, the CNA approach, the whole body vibration technique, the spider cage or TerraSuit, TerraDogs, the goal-directed approach, the sensory approach, as well as the assisted robotic off-gate training. So in the following, I will be sharing with you some videos. I have the parents' consent on this, but please do not record from your devices. So in the first example, we can see the child working on her upper part, strengthening the upper limbs and the thorax. So it's a kind of a bottom-up approach where the therapist wanted to strengthen her upper limbs. However, this will really positively affect her sitting abilities. Same for when we are working on the core muscle activation during our sessions, so with the aim to improve the co-contraction between core muscles and trunk, and therefore to improve the sitting abilities. The strengthening program can also be applied in a different way while the child is more engaged in playing. For example, as you see in these two examples, we are aiming to activate the trunk muscles as well as the pelvic muscles while the child is visually engaged, so in order to improve either the sitting position or the standing position. Different strategies, as I mentioned, can be applied as well when the child is engaged in a game. So in this way, the child will be able to generalize the achievement, the achieved skills. So in the first example, the child is working on improving her sitting abilities. However, she's only focused on just dropping the ball in the container. She's not focused on sitting. However, this will help her to improve her sitting abilities in a more proper way. Same for the second example, where the child is, when she was standing, she was watching her iPad. She was asked to just do the transition and participate as much as she can in performing the transition from sitting to standing and to maintain standing while she's visually engaged. Other tools as well can be used to improve postural reactions in children, such as swings, balls. So with these tools, we provide the child with the appropriate sensory input in order to stimulate his vestibular system, and this will help him to better develop his coordination and balance skills. Combined techniques can also be used. For example, in the first case, in the first video, you are watching the child. We are aiming to improve postural control in standing, while we use the whole body vibration technique and the spider cage assistant to provide the appropriate proprioceptive input. And you can see the other child jumping in the cage. So she's enjoying jumping in the cage, but for us we have specific goals behind this activity to activate her lower limb muscles, to give her to let her jump independently by the end of our treatment. And now she's able to do it. High-tech tools are also adopted at our center, specifically when it comes to gait training. So even if the child is not initiating steps, for us it's really important to help him to experience this high functional task. By doing this, we can activate different muscles, and we can stimulate areas in the brain where area in the brains where usually he cannot stimulate it during his life. So the defined goals were scored according to GAS for each child. So the goals marked in the red area were not achieved. However, the goals marked in the green area were achieved. So we noticed that for the first child, most of the goals were achieved in the course of the PT intervention. Same for the second child, knowing that these children were benefiting from an intensive program, based on 4 to 6 sessions per week. However, the third child was half of the goals were achieved, knowing that even if the goal is marked less than expected, this means that the child was able to show slight improvement compared to the baseline. Regarding the fourth child who was only coming for an intensive program, we can notice that he was not able to achieve his goals and he needs more intervention and time to reach his goals. And the fifth child, who is a really high functional child, we noticed that he was able to achieve all of the goals. The T-score will help us, as I mentioned, to evaluate the overall goal achievement per year. So T-score for the first child revealed the highest score in 2021, and since parents are documenting on a daily basis the head drops and the seizures, so we were able maybe to correlate this high increase in achieving goals with the lowest average number of head drops per week in 2021 compared to 2020 and 2022. The second child also showed the highest increase in 2021, knowing that parents decided to stop the clobazam in the beginning of January 2021, and the therapist and the parents noticed a significant improvement in by the end of 2021. So for the rest of kids, the highest score, maybe they were, the third child, he showed like stable changes, but the last increase maybe in 2022 might be related, coincided with the stopping of keto diet and the increased seizures. However, the rest of kids, the fourth child who was only coming for intensive program, he was not able to achieve his goals, but the fifth child was able to achieve his goals. So if you can have a global clinical observation based on the baseline profile and the last profile, we noticed that most our kids presented challenges related to sitting, standing, and walking. However, after 3 years of follow-up, so you can see when the area marked in green, they showed significant improvement in this based on goal. So in conclusion, while different factors can affect motor improvement in CDD, regular PT sessions seem to enhance motor skills. Gross motor skills improvement might be largely affected by medication and by seizures, so we need to find the balance between two. There is major limitation regarding the study. It's only a preliminary study, descriptive study based on 5 case series. We need to enroll a larger population in order to have a more solid conclusion regarding this, and we need to include validated tools, and as Mr. Majid Jafar, the work is in progress to create validated tools to help us, and I hope we'll collaborate to build this, to have this more powerful analysis based on different aspects. So you can see here one of our kids helping an ambulant child, helping another child while walking, so in a very joyful environment. So thank you for your attention, and I would like to thank the whole PT team at High Hopes who collaborated largely to complete this work. Thank you.